Let's begin. Today's case study, we're going over a 53-year-old female, history of palpitations, and no abnormal ECG was acquired. So could kind of be anything. We don't have a whole lot of information there. So what the plan is we're going to do a 4-catheter study with 3-dimensional mapping, utilizing 3 steerable quadrupolar catheters, so 4 electrodes, and a steerable decapolar for the coronary sinus with 10 electrodes, so decapolar. For ablation, if we choose to go forward with ablation, we will be using a contact force ablation catheter with a DF curve, meaning bidirectional. All right, here is our baseline. What do you see? Okay. So what I'm looking at here is we have our surface ECG. Looking at just that, I can see a P wave, a QRS, and here's my T wave. Remember that, let me make this a little bit smaller. Remember that with EP studies, we typically stretch out that sweep speed to 150 or 200 milliseconds. So that causes this QRS to look wide, but this is actually a narrow QRS complex. So again, P wave, QRS, T, narrow complex, and it looks like a pretty regular rhythm coming in at 760 milliseconds. Breaking it down to the intracardiacs, we have our HRA catheter. So this just shows an A, and that's going to line up underneath the P wave. Okay. Next, we have our His channels. And our His channels here, let me move over so you have more room. All of these are atrial signals, so that'll be an A lining up under the P wave. All of these guys are ventricular signals, or V, lining up under the QRS. And this little fella right in between, right here, is our sharp hiss. So we'll mark that with an H for hiss. Okay. Next, we have our coronary sinus. So decapolar, remember we're going to utilize those pairs. So with 10 electrodes, we get 5 channels with our standard setup. Our His catheter, we did a little differently to get 3 channels. All right, we remember our coronary sinus sits in between the atrium and ventricle, looping around to the left side of the heart on that posterior aspect. So again, lining up under the P wave. We'll start fresh here. So lining up under the P wave, all of these are atrial signals. Okay, so these are all A's, with CS910 on the proximal side, so at the ostium, so more a right atrial, and on CS12, that's our distal electrode, so left side of the heart. Okay. And then this signal here, this little smaller signal, is the V lining up underneath our QRS. So that's ventricular activation. Okay. And we notice that the atrial activation goes from right side to left side. There's a slight little lean to that. Last catheter we have in is our RV catheter. Okay, RVA standing for RV apex. All right, so we only have 1 signal on there because it's so far away from the atrium, and that smaller atrial wall thickness, right? We're not going to see that signal. So the only thing we see here is a V lining up underneath the QRS. All right, so let's put all this together and we see that we are in sinus rhythm, right? We start at the HRA, which is going to be positioned by the SA node. That's our first atrial event. Then it hits the His bundle, proximal CS to distal CS. So it goes high to low in the heart, right to left. Okay, then we have our His and our V. So this is sinus rhythm. Go to our next screen here. So going into the study now, we're skipping some of those steps, and I'm just going to move to kind of the exciting things that happened. We are doing extrastimulus testing. So we have our drivetrain of 8 beats at 600 milliseconds. And our extrastimulus, oh, come on there. There we go. Drivetrain at 600 and our extrastimulus at 200. Okay. So first thing is we're noticing that we are pacing. Where are we pacing from? Did we capture? And if it captured, did it actually conduct to the next chamber? So push pause if you want to figure this out on your own. Do that throughout these presentations, please. So I can see we are pacing from CS 910. So we're pacing proximal CS, which is going to capture more of that right side. Okay, so CS 910, I can tell that because we have this saturated signal here. We're not able to send and receive at the same time. So that's how I could tell we're pacing there. So we have our drivetrain of 8 beats. Let me pull this up a little bit if I can. There we go. So just out of ease, I only have beat 7 and beat 8 of that drivetrain displayed. Okay, so after the drivetrain, we have our extrastimulus here at 200. All right, so these last 2 beats of the drivetrain, let's make sure they captured. So we paced at CS 910, and indeed we captured the atrium with that CS signal, lining up under the P wave. We know that's atrial. And then from this A, it conducted to the adjacent chamber, down to the His and the V. Okay, beat number 8 of that drivetrain came in. We captured the atrial tissue again, and it conducted to the ventricle. Don't forget, you can use surface ECG to make that easier. It's always easy to see the QRS up top. Sometimes this gets a little muddy. All right, now let's move in to our extrastimulus. Here, extrastimulus at 220. So this is our PAC. PAC because we're pacing the atrium. Did it capture? Here I see my pacing artifact, which is really nice when we have that stim channel. But look at this A on the previous beat. Here's our pacing artifact, and we don't see any atrial signal. Remember this, that's coming in before that pacing artifact, that's the V from the beat before. So here we pace the atrium, and this impulse came in so early, the atrial tissue itself could not depolarize. So what do we want to call that? We have 2 choices with atrial pacing. When we are doing extrastimulus testing, we're going to use the label ERP. And when we're doing atrial pacing, we have 2 options. So it's going to be ERP either way because of that extrastimulus testing, right? But is it AV node or atrial? We can tell the impulse came in so soon, we did not capture the atrial tissue itself. The atrial tissue itself said, nope, nope, I'm not ready to receive another impulse. I cannot depolarize. The tissue is still refractory. So that would be atrial ERP because the atrial tissue is what hit its refractory period. Okay. All right, moving on. Okay, a little further down the road, it looks like we're pacing here at 470. I want to say we're probably decremental pacing, but it's not shown here because I'm not seeing the rate change. So where are we pacing from? Did we capture and did we conduct? We're going to do that same thing. Look at big picture and you can see wide QRS complexes with an immediate pacing signal or that stimulus immediately before. This is a big clue that we are ventricular pacing. Pacing artifact, wide QRS complex. We're pacing and capturing the V. We're doing that via the RVA, or the RV channel. You can see our pacing spike lining up with the stim channel. That pacing artifact can be seen throughout, right? We're not able to notice that immediate depolarization because we're just showing that one channel. But like I said, you can see that on the surface QRS. So pacing and capturing the ventricle. Did it conduct? All right, so we paced the V, it captured, and let's look at what's easy. This is an easy way to see the V, QRS, but we're going to call that V. HRA is an easy way to see the A. So V to A. It did capture, it did conduct. Okay, and we see A's throughout. However, something is different here. It's labeled initiation. So we did initiate the tachycardia, but you can see that the A's after this beat no longer are correlated with the ventricular events. So this is that last beat that initiated the tachycardia. It's not often that we're initiating SVTs with ventricular pacing, but we could see that in any rhythm, but it's more common in certain ones that we won't get into today. All right, so with ventricular pacing, we initiated tachycardia. We cannot interpret a whole lot because we're still pacing throughout. We need to come off pacing. Here's our tachycardia. Take a minute and see what's going on here. Okay, let me go back and point one thing out. All right, one more. There, we're keeping up. Remember here's our HRAA, here's our CSA, high to low, right to left, okay? Notice how this HRA is before the atrial signal on the coronary sinus. So now let's look at tachycardia. Few things that we notice is one, this tachycardia is 1-to-1, meaning there's an atrial event for every ventricular event. Okay? It's narrow complex, so this is not ventricular tachycardia. Now, if it was wide complex, there could be aberrant conduction. It doesn't mean VT. But here I see a narrow complex, so I know this is a supraventricular rhythm, okay, with 1-to-1 conduction. All of these clues, you want to start taking notes of those. They're helpful to help you figure out what's happening. And as I mentioned on that slide I went back to, now, whoops, excuse me there, my line's not super straight, but you can see that A on both the HRA and the CS are happening at about the same time. Well, that's weird. So how does that happen? Must be something that's happening somewhere in between. Okay, so let's look at this tachycardia, A to B, A to B, A to B throughout, very consistent. Things that we can look at is we're going to look at the hiss. We're going to see if there's any activation changes throughout, right? We're going to look at the VA interval, time from the surface QRS to that next A, okay? So here's my surface QRS. Here's my earliest atrial event. This time is long. Long meaning greater than 60 milliseconds. It's one more clue to add to our arsenal. Okay, tachycardia continues. So let's test it. As we're going into testing, let's think about what this could be. This rhythm could be any of the big tachycardias, the big SVTs. So not AFib, because it's not chaotic, and not atrial flutter, because, I mean, it could be 1-to-1 atrial flutter, but that's a very slow rate, so unlikely. So the big three SVTs, atrial tach, AVNRT, and AVRT. This test helps us determine which one, or helps rule out options. Take a few moments to look at that, but I'm going to jump into explaining. Just looking at surface, you could see it's changed. Here, we have wide complex. Pacing artifact, YV. So we are pacing the ventricle on this half of the slide. Okay? Here, we're back to narrow QRS complex. So pacing ventricle, not pacing ventricle. Surface EKG can be very helpful. So we're pacing the ventricle via the RV catheter at a rate here of 410. Okay, so that is our PCL, is sometimes how it's labeled for pacing cycle length. Okay, so that's 400. 410. I should have said this A to A, that rate is 450. So the maneuver we're doing is ventricular overdrive pacing, sometimes referred to as a type of entrainment or Marotti maneuver. Okay. To perform this maneuver, you pace faster than the tachycardia cycle length, which we did from 450, we paced at 410. So we pace the ventricle, but we also have to speed up the atrial rate. So this paced then goes to this A to A, and yes, this A to A is also 410. So we paced and sped up the tachycardia. When we stop pacing, tachycardia has to continue. If we meet those, then we can interpret. Step one now in interpreting, once we've determined we did indeed entrain, is to look at our response. Okay? What is our response here to this entrainment technique? Here, we pace the ventricle. Remember, we can't see it there, but we can definitely see our V here. Here, our V is tucked in tight. So we have a V. Then we have an atrial signal. Then we have an atrial signal. And then V. So this is a VAAV response. This is the response seen in atrial tachycardia. All right, so we decided to map this tachycardia. So with that, the sweep speed now has changed. You can see our rate is still at 450, but you can see how close those signals are together. It's because just to show the whole more of the tachycardia, we shrunk the sweep speed to fit it on the screen. Okay, this is just for presentations. During the rhythm, we still had, or the case, we still had it at 200. So now what we're doing is we are moving around our ablation catheter around the atrium to find the earliest site of activation. Little troubleshooting tip for those that are new. Notice how all of a sudden now we have all this noise. This noise, here, see all that 60 cycle. Most likely what happened, the only thing that's changed is we put an ablation catheter in. Something goes in, something changes, and we see noise like that. Pretty sure the grounding pad has not been plugged into the generator yet. Plugging that in will take care of that noise. Okay, so let's see. Took care of that noise, but now we are still in tachycardia. We are moving around the catheter to find the earliest atrial activation. With ATAC, you have to map in tachycardia, right? We actually have to find the earliest breakout spot, okay? It's not structural like AFib where we're just doing an anatomical ablation. All right, let's continue tachycardia mapping. Here we have it stretched back out so we can see it at 150 sweep speed. So rate's still the same, 450. What do we notice? primarily, let's look at our ablation channel. Do we want to burn here? No, right? We don't want to burn at this spot. Here, where we have our earliest atrial signal that we found, which is preceding the P wave, right? Our atrial signal here is 42 milliseconds before the P wave, okay? This is ideal. This is where we want to burn, except what's this signal, right? A, V, this is a hiss. We don't want to burn on that hiss, or we could affect our normal conduction system, right? So this is something you'll want to mark on the mapping system or call out to the physician. If they say to ablate, make sure that they are aware and you've seen and pointed out this hiss signal. So that's our earliest site. And here's what our 3D map looks like. Okay. Quick breakdown of what this is we are looking down the barrel of the tricuspid valve. So here's my tricuspid valve. Okay. So I know, without even looking at the image here, I know this is LAO because we are looking through the valve. That would make this area the mitral valve. Here's my coronary sinus. So this would be where 910 is. Here's 1, 2. Okay. So up here is my SVC, and can't really see so well down here, but IVC. Lateral wall, septal wall. And this spot is where our bundle of hiss is located. That's where we're getting our hiss signal. So if this is where my hiss is located, and you can see this is my earliest site. Early site, depending on the mapping system used, is either white or red. Okay, so here that earliest site is white, and then it gets later as it spreads throughout the chamber. It's like if you drop a pebble in a pond, you see those ripples go out. Same with this activation map. Right? So our earliest site is at the same place as the bundle of hiss. What are you going to do? So there's a couple of techniques that can be utilized. The physician, in this instance, decided to have an initial talk with the patient because this had not come up in their pre-discussion. So they wanted to talk about risk factors because the risk factors are changing, right? Because now we have a critical structure here. Okay, where else could this be? If this is on the septum, it could come from the left atrium. I don't think so. Normally it looks slightly different on mapping, but could be somewhere in the left atrium. So the physician might want to go into the left atrium to check to see if there's anything earlier. 42 milliseconds, pretty darn early though. And then what sits in between these structures? Let me find my heart here. If you look in between right atrium, left atrium, right here is our aorta. So coming in with our aorta here, our non-coronary cusp is right in this area. If the atrial tachycardia is mapping out to the bundle of hiss, very often this is a non-coronary cusp atrial tach. And if we burn in that non-coronary cusp, we will get that tachycardia. So in this instance, the physician decided to talk to the patient about further risks and come back to complete that ablation at a later time. And that's all we have. So there you go. Thank you.